I'm going to invite now Dr. Assad and her panel members, again, all esteemed members, to join us, because now we're moving on to, you sort of passed the active phase of your treatment. You're still in follow-up, maybe getting imaging, as Dr. Robinette was mentioning, but now all sorts of other issues crop up. So it may be that you're at the podium, actually, Dr. Assad, since you're the primary harasser of all. And, or is there enough seats? Am I bad at counting? I can't see.
Well, good afternoon to the folks joining us from Detroit, also Lansing and Flint. It is my honor and pleasure to be among this wonderful group of panelists today. And we're happy to be giving you some of our thoughts and insight on the after treatment, or how to maximize your outcomes and minimize your symptoms after you've completed treatment for for cancer. I'm going to have each member of the panelists introduce themselves, their expertise, and their research interests, and then we're going to go back and give you a little bit more insight and thoughts that I hope you find useful today. So I'm a breast oncologist. So I'm part of a multidisciplinary team, primarily treating breast cancer. And as you heard from my colleagues today, the multidisciplinary team includes the surgical oncologist, radiation oncologists like Dr. Ye. We also have the medical oncologists, pathologists, and radiologists. And so we all are part of a team essentially made to take care of your cancer. My research interests focus on new therapies that are less toxic and more effective. I'm particularly interested in triple-negative breast cancer, which tends to be the most aggressive type of breast cancer. I'm also a member of the Phase 1 and Early Therapeutics Clinical Trials Program, where we study new drugs in development. And I'm also particularly interested in mechanisms of resistance. So with that, I'm going to hand it over to the panelists to introduce themselves.
So I am Felicity Harper. I wear a couple of different hats. I am a clinical psychologist, and I see patients at Karmanos downtown. So I see patients, their families, and I see patients all across the continuum, from biopsy, new diagnosis, all the way to end of life. I am also part of the Cancer Center leadership, so I'm the Associate Center Director for Population Sciences Research. So I'm also a professor in the Department of Oncology, and that allows me to the opportunity to be able to do research on outcomes such as quality of life. I think you heard Dr. Thompson speak earlier. She and I have a grant where we are looking at factors that might predict differences, and in particular disparities among African American cancer survivors. I also have developed a smartphone app that's called My Patient Pal to help patients in treatment better manage their symptoms.
Hello? Okay. My name is Jennifer Dimmer, and I am a professor of oncology. I'm also a program leader for the Population Studies and Disparities Research Program at Karmanos. I am trained as a cancer epidemiologist, and epidemiologists are usually people who study risk factors for certain diseases or things that are prognostic indicators. And so most of my research, so I have a few different areas, and a lot of my funded research, I look at patients who have more unusual characteristics in an effort to identify inherited genetic factors for common diseases. So I look at a lot of risk factors for prostate cancer and breast cancer. And when I say patients with more unusual characteristics, I'm looking at patients who have clustering of cancers within close family members, patients that are diagnosed with cancer at a very early age, or patients who end up being diagnosed with multiple primary cancers. So that's a major area of research for me. As you'll hear about in a little bit, not many people at Karmanos know that one of my part-time passions is fitness. And so I've been actually a fitness instructor for more than 30 years. And thank you. And so one of the projects that I run is really fun for me because it allows me to kind of marry that part-time passion with my career. So I'll tell you a little bit about that exercise intervention in a bit.
So good afternoon, everyone. My name is Dr. Carmen Stokes, and I am a nurse navigator with the Gavini Center for Cancer Prevention. My background is 29 years as a registered nurse and 23 years as a certified family nurse practitioner, but also have spent 20 years on the academic side teaching nursing full-time. And at the end of COVID, like many of you, thought, you know, life should be a little different emerging out of this, and I decided to go back into the clinical setting to have a direct impact on patients born from personal and family experiences with cancer, and just really wanting to make a difference. And we know that education can change things if we spend a lot of time telling people what they need to do, but we don't always help them connect to why it's so important. So that's, I think, where my passion is and my expertise is. But history as a community health organizer and a lot of research and community-based participatory research. So excited to be here and to talk about ways that you can prevent cancer recurrence even after a cancer diagnosis has occurred. Thank you.
Hello, my name's Josephine Roach, and I'm a breast cancer advocate. I am a speaker and an author as well, and I chair the Coleman Michigan Leadership Council. I am a member of KCAP, and most importantly, I'm a 5-year breast cancer survivor. Thank you. I speak to a lot of people about breast cancer, especially when they're newly diagnosed, and it was overwhelming listening to Bill Winkler and going back. And those emotions right on. But now I'm on the other side. So now I'm into survivorship, and I'm happy to be here to explain that there is life after cancer. And I did take something that wasn't so pleasant, changed my career, and turned it into something, I think, positive by speaking to people who are newly diagnosed and following them through their journey. So I'm happy to be here, and I thank you.
So as you can see, I'm joined by a wonderful group of panelists, and we hope to share with you some of our thoughts about how to optimize your care after treatment. As you already heard, cancer treatment may involve surgery, radiation therapy, and systemic therapy, which could be chemo, could be hormonal, could be targeted, or immunotherapy. Some of these therapies are taken IV, some are oral. For early stage disease, we give it for a pre-specified period of time and then we stop, and patients are moved on to what we call active surveillance. So as a medical oncologist, my role when I see patients who have completed their active treatment is to first manage any side effects or symptoms that they might have. Some of those symptoms may include swelling or lymphedema, which can happen really anywhere that you, whenever you're manipulating lymph nodes or doing any sort of procedures to lymph nodes. So we do physical therapy for that. Also, we can use compression sleeves and so forth. Peripheral neuropathy is maybe a term that you may have heard. That's when you can develop numbness and tingling in the hands and feet from prior therapy. So we monitor for that and we manage it. There are medications that we can use to treat also peripheral neuropathy if it arises. A lot of the symptoms I help manage are menopausal symptoms and sexual dysfunction, which is also very important, especially if you're treating younger patients. It's important to ask about them and to also manage them. And there are ways that we can manage them, non-hormonally as well. And then we monitor for immune-mediated side effects, of course, that can happen anytime during or after treatment. The second aspect that I do as a medical oncologist is to decrease the risk of cancer recurrence. And you will hear from my colleagues today about lifestyle modifications that you can do that can reduce your risk of recurrence or new breast cancer. But also, in addition to those, I want to add smoking cessation. You know, smoking's associated with not just lung cancer, but all types of cancer, and then also limiting alcohol intake, because that also increases risk of cancer. Sometimes we use medications. For breast cancer, we use meds like tamoxifen and similar medicines that do reduce the risk of recurrence and also new breast cancers. And you will hear from my colleagues as well about ways to detect recurrence or new cancers, especially if you are higher risk based on your genetics. And finally, detecting a recurrence if it occurs, right? Patients who have had cancer tend to worry about the cancer coming back, and it's important to continue to follow up patients, manage and work up problems as they arise. Sometimes we use imaging on a routine basis, like CT scans of the chest to follow up lung cancer patients, mammograms for breast cancer patients, and so forth. Sometimes we also use blood tests to also assess for recurrence. So with that, I'm going to pass it on to the panelists to talk to you a little bit more about lifestyle modifications and things that you can do to optimize your outcome.
So as a clinical psychologist, you know, one of the main things that I do is helping people to kind of manage their emotional well-being and their mental health. You know, and I said, as I talked about, you know, I do this across all the continuum, but I think in particular that one area that tends to be very hard and maybe isn't always as well recognized as when people are diagnosed is when people finish treatment. And this can be a hard transition for people who have been going through radiation, people who've been going through chemotherapy, is that, you know, you're going to the cancer center, you're having treatment, you're having blood work, you see your doctor. And in some ways, there's kind of a prescribed routine, like you know what you're doing with your days, and it can be difficult once that active treatment ends because people sort of then wonder, well, what do I do now? And often is the case is that many people in your life are saying, well, you're cured, right? You're great. Okay, let's go back to daily living. And I think that, you know, for cancer patients, it's you come to an understanding that you can't sort of go back often to where you were. So developing a sense of normalcy requires that you sort of develop a new normal. And I think part of that process is kind of making that transition from being a cancer patient to being a person with cancer, someone who has been through cancer, someone who, you know, is kind of dealing with that aftermath. And what that can often include is dealing with, you know, complications of treatment, trying to sort of figure out how to manage side effects, particularly when you're not in that cancer care setting. What do you do about that? And very often patients will say to me is, when will things feel the same? When will I feel like myself again? And one of the main things and sort of a recurring theme is having to think about adjusting your expectations about what you should be doing. So I often hear patients say, well, I used to do that before, or before cancer, I did X, Y, and Z. And I'll tell them is that, you know what, but now you have cancer or you have had cancer and things aren't the same. So what you might expect that you would be able to do before, maybe you can't do that, particularly if you're early on in survivorship, because we do know some of these, at least the post-treatment complications, do get better over time. But I think that's really important to kind of say, all right, I have to think about, you know, where I am and what I can do, and I have to balance that with what I want to do, because I think there can create, you know, I think that's one of the areas that can put people at risk for depression is this idea that, well, I should be doing all these things, when in reality maybe you don't want to be doing those things, or they're not necessarily things that you can do right now. Another piece of this, as Dr. Assad mentioned, is cancer worries. So there's a lot of uncertainty about the future. Will the cancer return? And one of the things that I see is that people become very hypervigilant. They're monitoring their symptoms all the time, every pain, every ache, every bruise. And I think it's important to sort of balance that because I think a lot of people say, well, how did I know I have cancer? It just all of a sudden came up. So I think the natural reaction at that point is, well, now I've got to be careful to monitor everything. And one of the tips that I'll give to patients is that if there's something that bothers you, like for example, you have a headache, is monitor that. Give yourself a week or maybe 2 weeks and say, I'm going to keep track of this. And does it persist for that period of time? You can also always call your treatment team. So for example, if it's something like shortness of breath, you don't want to wait 2 weeks on that. But I think you can give yourself some guidelines and sort of pay attention to like, okay, how often is this happening? Does this come and go? What makes things better? Sometimes it's something that you can wait and talk to your doctor about at a follow-up. Sometimes it is something that you need to go to the hospital for, and that is something that your treatment care team can help you with. I think that there are sort of other things that people worry about, like how will I take care of my responsibilities? How will I do what I used to do around the house? How will I go back to work? I feel like a burden to other people. I don't want to make people feel guilty. People have things that are going on in your life. And I think the single most important thing that you can do for that is you can acknowledge your feelings, is you can say, I'm anxious, I'm sad, I'm worried, I'm afraid. And you know what? That's all normal. Every single feeling and thought that you've had, another person with cancer has experienced also. And a lot of other patients and survivors have felt the same way that you have. And I think the important thing about that is that you've got to, coming back to this idea of you got to figure out what you can do. You got to figure out what's important to you. And I think coming up with a plan of action helps a lot of people to deal with that uncertainty. So we know that complications from treatment, we know that worry about the future, those are all things that can contribute to clinical levels of anxiety and also depression. And I think the other two things that I'll just touch on briefly is managing stress, and I think the other thing is getting support. So Dr. Rana was mentioning the stress thermometer, which you rate your stress from 1 to 100. And I think that's a really good thing to keep tabs on, is to take what I call your stress temperature, because you're managing your, all these other side effects and you're taking your regular temperature, but I think it's just as important that you're taking your stress temperature because, as I said, stress is often related to things that people don't understand and causes our feelings of anger and depression and sadness and worry. So I think it's really important that you figure out, when are you feeling stressed? What are the signs that I know that I'm stressed? What makes me feel stressed? And then I think figuring out what works for you in terms of being able to manage that stress, whether that's making time to unwind, whether it's making time to do the things that you enjoy doing. Is that reading? Some people say quilting, sewing, working on cars, and I think as the other panelists will talk about, the importance of sleep and nutrition and exercise. And again, managing your expectations. You have to turn that worry into action and figure out what you can do and not focus on what you can't do. And I think the last thing that I'll kind of touch on is that asking for support. So very often, common reaction that survivors will talk about is feeling isolated and feeling alone, and that people don't want to talk about it. Again, as I said, it's sort of like, well, we've closed the chapter on that, and people in your life don't realize that there are still things that you're struggling with emotionally and sometimes physically. And people don't always want to talk about things, and I think it's important to find those people that you can talk about it. Find the people who are going to listen. Find the people who are going to build you up. And I think it's important to focus on what you want and what you need. So sometimes people will say, well, you felt fine yesterday. Why are you tired today? And I think it's really important to understand, how do you explain that to people who expect you to do the exact same thing every day? It's about having that conversation that it doesn't work for me the way it works for you right now. And I hear a lot of people say, well, people in my life who've never had cancer tell me that I should be doing X, Y, and Z. And I said, well, you go right back and tell them, well, when you've had cancer, you can then tell me about how I feel. So I'll just end there and sort of say, there are a lot of ways that you can help yourself and people in your life deal with this. But, it's then professionals like me, who are available, that when things start to be a little overwhelming, it's okay to get a little bit of help. And, as Megan said, there are a lot of resources out there for people, and I think it's important to realize when you need help and to ask for help.
So I'm going to talk to you a little bit about the benefits of physical activity. And first, I'd like to say that I think there's overwhelming scientific evidence of the benefits of physical activity to cancer, not just cancer risk, but outcomes. Some of these are cancer specific, so reducing risk of several different kinds of cancers, particularly hormone responsive cancers like prostate and breast and colorectal cancer. But there is even some evidence to suggest that regular exercise can prevent recurrence for certain cancers. And I know that this panel is really focused on sort of post-treatment effects of different health behaviors, but I'd like to encourage people to engage in regular physical activity as soon as possible after diagnosis, so that might even include an exercise program during treatment. So the evidence is so overwhelming that in 2012, the American Cancer Society assembled an expert panel and to come up with some recommendations for both nutrition and physical activity, and I'll kind of restrict my comments to exercise. But it was first suggested that any cancer survivor engage in at least 150 minutes per more of moderate to vigorous physical activity per week. And that they should try to engage in, again, this behavior as soon as possible after diagnosis. And I think these recommendations were most recently updated, and I get sort of reinforcing the notion of the benefits of physical activity, and they've upped this to up to 300 minutes of activity per week. So I suggest, some of it is cancer specific, but some of it is, cancer survivors will achieve the same benefits as anybody else. So engaging in regular physical activity, you're going to increase your cardiovascular endurance, you're going to gain lean muscle. If something you aspire to do is to lose weight, a regular exercise program is a great way to do that. So some of the problem in engaging in regular physical activity. So my research group and others have shown that even though there are these recommendations out there, it's about 1/4 of cancer survivors actually meet these recommendations. And I think in the state of Michigan, it's about 20% of cancer survivors achieve this. We see some pretty significant disparities in engagement in regular physical activities by gender, by age of diagnosis, by race, by where you live. So we know that patients that live in more rural regions have a harder time engaging in physical activity programs. So it might be sort of a resource-related thing. So I'd just like to say that there is no one physical activity program that's right for everybody. So you have to kind of make those decisions about what kind of exercise program is good for you. It may be just going out and taking a brisk walk for the day. It's just getting up and moving. And to kind of address somewhat some of the things that Felicity suggested about stress and anxiety and depression, there are lots of physiologic benefits to regular exercise, but there's a lot of mental health and psychologic benefits as well. So it can really improve your quality of life. So I was suggesting that sort of a program that we've started at Karmanos. It started in 2018, and so we've been running it for a few years now. And the CAPABLE program, CAPABLE stands for Cross Training and Physical Activity, a Better Life Experience. And this is a 12-week fitness program. It combines high-intensity interval training with strength training. It's a free program that's subsidized by Karmanos, but I will say that it is not limited to Karmanos patients. Anybody can participate in this program. We have 7 different performance sites, most of which are located throughout Southeast Michigan, but we've just opened an additional performance site in Petoskey. We've got 2 more performance sites that are opening up this year. And again, it's a 12-week free program. It offers cancer survivors 3 days per week, 60 minutes of supervised exercise. It's coached by a level 1 certified CrossFit coach. And I know some of you are, if you know anything about CrossFit, it seems a little bit scary. Felicity and I actually both happen to be level 1, level 2 certified CrossFit coaches. I actually participate as a coach in a number of my research studies, so it's really, really nice to see a bunch of former capable participants out in the audience. So I guess I'd like to just conclude by saying if there's anybody in this room or if you know of anybody that would be interested in a program like this, please come up and see me. I also know that there is a list at the Karmanos table with the Office of Community Outreach and Engagement, and if you can provide me that contact information, I can put you in touch with somebody that has more information about the program.
I just wanted to touch on a couple of things that my prior panelists said. As we all know, that the simplest definition of cancer is just an abnormal cell with uncontrolled growth. And when it comes to smoking, we release about 5,000 carcinogens, and what that does is damage the cells. And so then you have these abnormal cells and an opportunity for uncontrolled growth. And with alcohol, when you are metabolizing alcohol, it actually releases acetaldehydrogenase, which damages cells. So as you can see, it's really this cycle of things that damage cells, and then the body's not able to control the growth of those cells and get rid of those cells appropriately. But since we have a small amount of time left and a lot of our content does overlap, I am going to ask Josephine a couple questions, and I think that way we won't be saying exactly the same thing and we can hear back and forth. But I'm going to speak a little bit about nutrition, and I wanted to find out from a survivor, do you have any thoughts about nutrition and whether or not it has an actual impact on cancer?
Well, I believe it has, and I believe it does. You know, a lot of the, the preservatives in food seem to be an issue, and what we put on our crops and our vegetables is an issue as well. So I really did look at my nutrition, unfortunately, more so after being diagnosed, and I really took a hard look at it, and because my cancer was hormone driven, I decided to stay away, and I'm not completely, but from dairy, and I eat a lot of fish, and of course my plate is half vegetables and fruit, and I try to eat organic when I can.
That's great. And I think the American Institute for Cancer Research actually has a couple of things that they have put out. One of the things that they say is that 50% of the most common cancers actually are preventable. And so we really need to hold on to that, because a lot of times with cancer, we feel powerless. It's something that's uninvited that comes into our lives and it disrupts everything. But 50% of the most common cancers are preventable. And again, according to the American Institute for Cancer Research, prevention begins at the kitchen table. So there are things we can do. Only about 5 to 10% of cancers are genetic. The rest are considered spontaneous or some other issue. What happens a lot of times is what is followed through families are our dietary habits, the way that we eat, the things that we eat, and whether or not we're fit and active at all. So that's something to think about. In addition to that, the Cancer Council actually recommends only 4 servings of meat per week. And the standard American diet, which is also called the SAD diet, it is considered a SAD diet when you compare it to other cultures and other countries. Their incidence of cancer is lower, but their meat consumption is lower, and there are some physiological reasons to that. But what I will say is, if you're a traditional American and you love your meat, just try to cut back. You don't have to do everything at once. Be aware of the impact that meat has. One of the ways it does have an impact for the cancers that are hormonal dependent, think about the fact that perhaps our body's not properly regulating our hormones, and then we're taking in meat, which has been given antibiotics and additional hormones in order to produce more of it. And so then that disrupts our hormonal system even more. And then with the dietary guidelines of America, the ACS, and the World Health Organization, it also is recommended that you reduce your sugar intake. Sugar is considered 7 to 10 times more addictive than cocaine and heroin. And there's lots of scientific research to support that. So when you think about it, you're not imagining that it's difficult to give those things up. It is truly an addiction. But it has been said that cancer cells really thrive in high sugar environments. They feed off of that. They do not thrive in high oxygen environments. So when we're exercising, we're getting a lot of oxygen, which will destroy those abnormal cells. Another thing to think about is there are about 13 cancers that are specifically related to obesity, and almost 48% of American citizens are either overweight or obese by medical definition. So we really want to work on small cuts. If we can cut back a little bit each week, we can lose a half a pound. No big deal there, right? That's just eliminating one snack a day. But in a year, you could lose 26 pounds just by losing a half a pound a week. So slow progress is still progress, and we want to keep that in mind. So another question that I have for you is that research suggests that sleep is critical to our health. And prior to your diagnosis, how was your sleep, or did you notice anything about your sleep?
My sleep wasn't well. I didn't sleep very well. And again, stress played into that as well, and being my mother's caregiver. And I would get probably about 5 hours of sleep a night. But that's improved. Again, changing my diet, exercising. I definitely have improved on my sleep, and now I'm up to 7 hours. So I think that is quite a bit of an improvement, right?
That's excellent. So that's another area for us to think about. And many of us are very busy in our lives, and one of the things that we sacrifice often is sleep. But when you sacrifice your sleep, you're actually sacrificing your health. So some recent research suggests that people who sleep less than 6 hours a night have a 41% higher risk of getting cancer diagnosis. 41%. And so the ideal sleep is between 7 and 9 hours a night. And I know as working adults, many of us think that's impossible, at least the 9 hours a night. But you want to try to get as close to 7 as possible. The first place to start is to think about your sleep hygiene. So when we have babies in our lives, we're very familiar with setting up a routine for the baby, giving them a warm bath, kind of creating, a familiar situation so that they know that it's time to sleep and to rest. With the age of technology, many of us go to bed with our phones. So there's research to show that your phones, your computers, and your TV all emit blue light. Blue light by the brain is interpreted like sunlight, and it throws your circadian rhythm off. So your brain does not know that it is time to sleep and it is time to rest. And this is a high contributing factor to why people don't sleep well. So you need to remove all of the blue light at least an hour before you sleep. And that includes the television. So turn the news off, which is probably stressing most of us out more anyway. And you can read. Reading does seem to help to induce sleep. Another thing is warm baths. And Josephine and I laughed about this. A lot of the new homes no longer even include a tub as a part of the floor plan, right? But baths are medicinal. It's warm water. It helps to increase your circulation, get that oxygen flowing. Cancer cells don't thrive in highly oxygenated environments. But in addition to that, when I was a child growing up, a lot of times my mom, my grandmother, they would put Epsom salt in our baths, right? So it does decrease inflammation, and inflammation destroys cells, which makes them abnormal. It's a big cycle, right? But in addition to that, there's a lot of research that suggests that magnesium helps us sleep better. Magnesium actually helps to relax the body. And what are Epsom salts? Magnesium salts, right? So there's something to, like the old wives' tale or therapy. So you want to try to make sure that you're getting your sleep. Reading, you can listen to restful music, have a gratitude journal, but you just want to have a routine at bedtime that will help to induce your sleep. And so then the final question that I have for you is, was there anything in your history or in your life prior to your diagnosis that aligned with you being a high-risk patient?
It wasn't so much high risk. I mean, I did have risk. Of course, the two greatest risk factors of having breast cancer is being a woman and aging. So that's all of us. So that's a great reason. Get your mammogram and, get yourself checked. Also, I started my menarche, my cycle later. I think I was about 14 or 15, and I have no children. And I am overweight. So those were, but I'm sure you're going to tell us what high risks are. Those were my risks.
Well, I appreciate you being honest, and you're beautiful. But I do think I love your confidence and your honesty, because being overweight or being obese are medical definitions. And a lot of times people are offended by the idea or the thought. But we need to be able to embrace where we are so that we can make improvements. So high-risk patients, it includes quite a few things. We won't go through them all. You've heard a lot of different things throughout today, but of course, family history, especially a first-degree relative. As Josephine and I were talking, that includes male relatives. We don't talk a lot about male breast cancer, but even outside of that, prostate cancer, colorectal cancer, those are a cluster of different cancers where we should be more aware of the potential need for genetic testing. Starting your cycle early and having menopause late, so there are more years that you're actually having a cycle. And if you've ever been told that you have the BRCA1 or the BRCA2 gene, but also dense breasts. So we really want to encourage screening in that case, your mammographies, which can start earlier based on some of that history. If they order MRI or ultrasound, someone mentioned earlier, don't be paralyzed with fear, follow up, so that we know what's actually happening and going on. Mammograms, even when they call you back, that's scary, and I've been there. That's scary. We need you to come back. Doesn't mean that it's going to be cancer, right? But some people get paralyzed there. Most of the time, it actually isn't. But you may find something, a fibroadenoma or something there. So, and then there are interventions, chemoprevention, as well as surgery that people sometimes will elect to have. We know Angelina Jolie is an example of someone who might do that. So before we finish out, are there any questions or thoughts that you had for me?
Well, I know you did mention again about, and we did talk about this earlier about heredity. And my mother had a half sister that had breast cancer. That's the only family member in my family that had breast cancer. And is that significant?
Well, it could be, but given that they don't share both parents, that would disrupt the idea that it's solely genetic. However, as we mentioned, there are 8 common cancers that are considered like hereditary syndromes, so they're familial. So not a gene necessarily passed down, but where you do see an increased incidence. And that includes breast, ovarian, colorectal, pancreatic, uterine, melanoma, and thyroid. So if you have some of those cancers in your family, people have been diagnosed younger than the age of 50, or a lot of those different diagnoses, it may still be appropriate to talk to your provider, and it may still be appropriate to consider some type of genetic testing depending on their assessment of you or evaluation of you.